Hello, everyone, and welcome to our moderated discussion, In Their Own Words, COVID-19 and the Future of the Healthcare Workforce. My name is Carmel Shachar, and I am the Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. I am delighted to welcome you to our virtual seminar. Before we get into the substantive discussion, a few minor housekeeping points, really the virtual equivalent of where the bathrooms are. As I have mentioned several times already, this is a moderated discussion, which means that we welcome your questions and we'll be incorporating them into the discussion. How do I submit questions? You may be asking right now. There are two ways to do it. The first and best way is to use the Zoom Q&A box, which if you scroll your cursor down towards the bottom of your Zoom window, you should find a button labeled Q&A. If you click on it and submit questions, our moderator will see those questions and be incorporating them into the discussion. You are also welcome to join the conversation on Twitter using the hashtag FutureHCW. Again, that's hashtag FutureHCW. If you submit a question using that hashtag, Petrie-Flom staff will be monitoring the hashtag and will pull that question and put it into the Zoom Q&A for our moderator to see. Two ways that will be not successful at submitting your question. The Zoom hand raise feature results in a really cute little blue hand, but we will not be monitoring or responding to those blue hands. Likewise, please do not try to use the chat to submit your questions. So Zoom Q&A or Twitter. With that covered, I would like to introduce our moderator who's going to take us through the next hour. He is Stephen Wood, visiting fellow at the Petrie-Flom Center, as well as an acute care nurse practitioner who practices emergency medicine in Boston, Massachusetts. Stephen, welcome.
Oh, thank you, Carmel. And first and foremost, thank you to Harvard Law School and the Petrie-Flom Center, especially Glenn Cohen, Carmel Shachar, Chloe Reichel, and Laura Chong, who have been big supporters and the catalyst for this program today. This is an important event, and it goes without saying that they were incredible for helping move this agenda forward, and I wanted to thank them for that. Second, hello and welcome everyone. Thank you for joining us today to In Their Own Words, COVID-19 and the Future of the Healthcare Workforce. This is a culmination of our digital symposium that can be accessed on the Petrie-Flom website blog, The Bill of Health. I encourage everyone to visit the symposium and read some, if not all, of the incredible pieces written by healthcare providers across the spectrum. There's many, many great pieces there, a lot of wonderful insight, and I think you'll enjoy reading these pieces. So March 11th of 2021 marked the one-year anniversary of the World Health Organization declaration of COVID-19 as a pandemic. And we went from wondering as healthcare providers if we would ever actually see a case of COVID in the United States to basically leading the world in the number of cases. And as healthcare providers, we have faced challenges that have tested us both clinically and emotionally this past year and beyond. Our symposium and this webinar is an exploration into that experience. So without further ado, I want to introduce our panelists. And in no particular order, we have Ben Passadlow, and Ben is a longtime leader in EMS and EMS advocacy with over 30 years of experience in very high volume 911 systems from Massachusetts to New Jersey. He's been involved in efforts at both the local, state, and federal levels in the area of system design, regionalization of EMS, and advancing EMS education. We thank you for joining us, Ben. We also have Molly Levine, who is a graduate nursing student in the family nurse practitioner track at Yale School of Nursing and a former EMT with Pro EMS. She has a wonderful piece talking about her experience in emergency medical services in kind of the hub of COVID in New York City. We have Cynthia Arofo, who's a cardiothoracic ICU nurse at Tufts Medical Center and a PhD in the student in the nursing program at Northeastern University here in Boston. And we have Dr. Lauren Autry, who's the assistant professor of medicine at the Boston University School of Medicine in the section of hematology and oncology at Boston Medical Center, with a focus on breast cancer care, but also managing all types of cancer. So I don't want to spend any more time having you hear my voice until later. I want to open this up to our panelists to talk a little bit about their experience. And again, in no particular order, except going left from right, I'm going to welcome Cynthia to start the program today. Cynthia, I'm giving you the floor.
Thank you. Good morning, everyone. My name is Cynthia Arofo. I use she, her pronouns. As Steve mentioned, I am a cardiothoracic ICU nurse at Tufts Medical Center. I am also a nursing PhD student at Northeastern. Northeastern has been my home for over 6 years, so I'm glad to be back here doing research. A lot of my research that I'm currently doing centers around health equity and social justice and ensuring that the structural inequities that are faced and have been exposed through this pandemic are really studied on a large scale. And we are doing everything in our power as health professionals, researchers, scientists to ensure that we're building equitable systems for people of all kinds. So I'm glad to bring that perspective here today. My father's in the audience, so I'll say hi to him and hope that he was able to figure out the Zoom format, but I'll pass it on to whoever wants to introduce themselves next. Thank you, everyone.
I'll go to Dr. Autry.
Oh, thank you. Yeah, I'm also really happy to be here. I'm a hematologist oncologist with a focus in breast cancer care at Boston Medical Center. And I was really, deeply affected by the pandemic. I think it really sort of upended, our lives in the hospital and really posed huge challenges for care. And I'm happy to be here and to talk about that.
Great, thank you, Dr. Autry. And Ben.
Hi, Steve. Hello, everyone. Yeah, I'm Ben Passadlow. I work for Armstrong Ambulance in Arlington, Mass, just outside of Boston. Also lately been really focused on vaccine operations that Armstrong's involved with, particularly focused on state public safety personnel and getting them vaccinated. And certainly am very interested with my colleagues, particularly people I talk with around the country from the International Association of EMS Chiefs, about how we can better support and resource EMS moving forward and integrate it, improve integration with the healthcare system as well as public safety in the coming days and months and years as we look at how we can better prepare for such events.
And Molly.
Hi, I'm Molly. I also use she, her pronouns. I lived in Boston for about 7 years for school. I studied public health, and then I worked as an EMT for about 2 years at Pro EMS in Cambridge, which included being in New York last April at the sort of height of the pandemic in the city. I feel like I've lived 2 lives this year, first as a frontline healthcare worker, EMT, and then now as a student. And being a student in the pandemic has been its own experience, and also learning a new system. The Yale New Haven healthcare system has similarities and also differences from Boston, so it's been interesting and kind of fun to compare my experience in both of those systems. I'm happy to be here.
Great. Well, thank you all. What we wanted to, the way we wanted to address this issue was to open up some questions and get some feedback. It's great that we have EMS, we have nursing, we have physician providers, we have students that can provide a really nice, well-rounded kind of overview of what it was like to be participating in healthcare as a provider during this pandemic. And not that it's over, we still have a ways to go. What I want to do is kind of open up the floor to some questions. I want to give each of you an opportunity to get to speak. We may not be able to have each of you answer each question, but I'll mix it up a little bit so we do get a well-rounded perspective. So the first kind of question that I want to throw out to the panelists is, what do you feel was really the most challenging aspect of working through the pandemic as a healthcare provider? And that can include your experience as a provider, but also your home life experience, your interactions with family and friends, but just kind of a general sense of what do you feel was the most challenging aspect of working through this pandemic as a provider? And Cynthia.
Yes, thank you, Steve. For me, in short, it most definitely was the fear. It became, a very personal and individual fear of contracting the virus, but this was extremely short-lived. Then it became a fear of inadvertently passing the virus to my immunocompromised patients on my home unit. As I mentioned, I'm a cardiothoracic ICU nurse, so we have a lot of pre and post-transplant patients. So that became a pending fear in my head. Then it became a fear of taking the virus home to my family. And it was a hyper-associative thinking that led me to see my father and my uncles, my aunts, my friends, and every Black patient that I had. And you can imagine how often that was, considering Black people were hospitalized at 2.9 times the rate of their white counterparts in the US, according to the CDC. Then it became the fear that the virus is going to devastate low-income communities and communities of color across the nation and the world because of longstanding structural inequities. And that constant thought that people who look like me and live in communities like my own are going to be dramatically impacted by the effects of the virus. That was also a very existential and widespread fear for myself. The fear, it was just stratified across so many levels, and it was sincerely overwhelming every time I'd have to put on an N95 and prep to get into a room. It just became levels of fear. But yeah, I would say the fear is the most challenging aspect.
I would agree. And I think, I'm so happy that we started out talking about the inequity of how this pandemic has been addressed. And that was seen at every level, from PPE resources to the patients that were being, managed, and that who you were, where you lived could really affect what kind of care you received, and your risk for getting the virus, but also dying from it. So Cynthia, thank you so much for addressing that piece. Anyone else have something to add to that? Molly?
Dr. Oshie.
Yeah, please, Molly.
So I loved what Cynthia said. That was really powerful, the way that she said that. So thank you. I arrived in New York last year on April 1st, and none of our patients were white. They were all Spanish speaking or Black patients. And there was like a huge inequity between the community public hospitals and the big academic hospitals, where the community hospitals felt like totally underwater, and then the academic hospitals felt normal, and it wasn't normal anywhere, but it kind of felt more normal. But no one was talking about it yet, because it was like the first 2 weeks in April and no one knew what was happening. And I was just craving like that data to prove like this is really unjust what's happening. And I think that created this real isolation, and this feeling that we were just like failing our patients because it was so unjust what we were seeing. So I think to me that really stood out as what was so hard for me and accelerated my own burnout, because I felt like we were just failing the people who were already the most vulnerable. And that was in New York, and then also in Boston and across the country, as we now know.
Yeah, I think that was a huge issue. And, I think my best friend always says I'm fueled by injustice. And I remember actually seeing that, one of our largest hospitals here in Boston was going to be getting all of the first, access to remdesivir an antiviral used for the management of COVID, and just how angry I was that that was going to be the case, and knowing that that was all about, about money and about access and about the patient volume that, they would see. It got rectified pretty quickly. I didn't have time to finish my letter, but it just really highlights, the important points that both Cynthia and Molly have discussed. Any other comments, either Lauren or Ben, or I have some other questions I was interested in. Yeah, Ben.
I thought those comments are excellent, especially from the front line. I think from for me, from like more of a management standpoint, I recall feeling very frustrated because as the surge came, for example, to New York City where Molly was, or other dense metro areas, we were anticipating that here in like Arlington, for example, and it never came in that level of severity. So that was kind of an interest, although we certainly had our surge. It didn't come at that level of so that it was almost, the anticipation was great, and the frustration between a wait and see attitude versus a preparedness attitude at all levels was, in kind of those two camps, was difficult to contend with, being kind of responsible for workforce, since we're talking about workforce today, and making sure that we resource our frontline providers, Cynthia, Molly, and yourself, people out there on the front lines taking care of patients, is how do we best prepare for that? And moving forward, what do we learn from what happened last year, so that, God forbid, we have future scenarios that we're able to do a better job, a safer job for our frontline workforce, so that they can take care of their communities. And to the equity point, that's absolutely critical, right? That we're taking care of our most vulnerable populations, our populations that have, don't traditionally have good access to care. And how do we improve that, both not just for disasters, but for everyday, because everyday preparedness and readiness helps us for disasters.
Thank you. Thank you. And Dr. Oshry, did you want to add anything to that?
I mean, I think that I completely agree with what's been said. I think that the feeling of just being really, the uncertainty, the lack of, feeling prepared, it was something that we're not used to, as medical providers. We're used to like having well-defined algorithms and, evidence-based strategies for managing things. And, suddenly we were kind of left with very little, information on which to base treatment. I think for managing cancer patients, we had so much uncertainty. Is it okay to continue treatment? Is it safe? Is it okay to bring patients to the hospital? And I agree with Cynthia that there was also just this sense that we were failing, our patients. I think, it really became evident, especially at the Safety Net Hospital where I work, that, things that had gone on for so long that led to, poor and minority patients being ill disproportionately, that it was just these, this overwhelming feeling of not being prepared, not being adequate, to the task, and just, failing.
Agreed. Thank you for those comments. This is something I think that we're going to need to continually address as a nation, if not as a world of healthcare providers. And I think COVID really helped to highlight the inequities that we face in healthcare, and that many of our patients have to struggle with daily. If there's anything good to come from COVID, I think that's an unfortunate way to get to this, but it will certainly hopefully open some eyes for people about these inequities and how we can avoid these, and what we can institute to help prevent this in the future. The other, building on that question, what in the short term, what are some of the effects you've seen of this pandemic on your ability to provide the care that you want to provide as a provider, be it a paramedic, EMT, nurse, or physician? What do you think some of the short-term effects have been? And what do you think that long-term impact may be on how you practice in the future? Dr. Autry, you look like you're ready to respond to that one as well.
You know, well, I touched on this in my blog post, but, you know, I think for a long time as an oncologist, it really troubled me that the patients I was caring for didn't have access to outpatient palliative care. And I think for oncology patients, it's a really critical facet of their care. And I think it would have been helpful for patients to have had that dimension, because when the pandemic hit, you know, we were suddenly faced with the task of having these advanced care, you know, conversations with patients by phone, you know, to talk about end of life issues in the setting of a cancer diagnosis. And it really was, it was just a really incredibly difficult thing. And I feel like if we had been better prepared, if we had had better support services, outpatient palliative care, which is really a well-recognized kind of standard that we lacked, you know, it would have made that process easier. You know, I also wrote about the fact that we had been without a social worker at my institution for a year when the pandemic hit. So, so many of not that a social worker could have fixed all the, you know, the problems, you know, that our patients were facing, but it was just that we had been under-resourced for so long that when this incredible stress came, you know, to our system, it really, really laid bare the shortcomings. And I'm hopeful that, you know, now having gone through this, that there will be a change and that we will be provided with greater support services.
I think that's incredibly important, and the things that I think have become most important, and certainly you had mentioned earlier, you know, we lacked evidence-based practice on how to manage this, you know, disease. We lacked, you know, real good guidelines on how to manage this disease, but it really accentuated how much we're lacking the support services that are critical, which are social work, case managers, and especially palliative care, and opening discussions about advanced directives well in advance of being in the situation where you need them. Did any of our other panelists want to expand on that question? Okay. What do you think some of the long-term impacts are going to have? What are going to be? Yeah. Let me rephrase. What are some of the long-term impacts that you see? You know, on your professions, be it, you know, in EMS, nursing, as a physician, that you think this pandemic will have? And this could be both positive and negatives. I'm going to pick on Cynthia because I think you look ready to answer this question, and I'm interested in your insight on this topic.
Thank you, Steve. I am ready.
Yes.
So I would say long-term, I'll give a positive that I envision. I envision more interprofessional camaraderie because of how stressful the pandemic had been on healthcare workers as a whole. So I represent nursing, but I know that speaking with my respiratory therapist on, you know, oh, wow, patient X is really getting better and they're off the ventilator and like they could probably go home, and like being able to interact with members of professions within healthcare worker has really been something that I've seen a lot, like a lot of cross-discipline support and collaboration, whether it be formally recognizing our environmental services staff and other support staff who are also on the front lines risking their lives as we are. ICU nurses teaching critical care concepts to medical surgical nurses, or getting like those regular COVID updates from our epidemiologists to the entire institution. And I'd really like to see that continue. And I know, you know, even as a student nurse working in clinical care, I knew that, you know, in healthcare, we often work in silos. So it'd be great to see that cross collaboration and support styles go through that dynamic shift some more.
I think that's a wonderful response. And I think that was something that I'm glad you mentioned, all the background support people, especially environmental services, who became critically important. And I think we're oftentimes under-recognized in their role that they're playing still today. with oftentimes, the lack of support that we see for our healthcare providers. Did anyone else want to comment on that? Ben?
Yes, Steve, yeah. Can you hear me? I know my audio is a little spotty. Good. Yeah, I think the long-term health effects on the workforce and on our patient population is a big unknown, right? So that's something we really need to think about, how that's going to affect our patient populations moving forward, whether it's in more chronic care or particularly acute emergency care, whether it's out in the field or in the hospital. We don't know yet what this is going to do to people. We already can kind of sense that it's, people who've been severely ill with this are likely to have problems down the road. So it's one thing. And I think also conversely for our staff, what are the long-term effects of this physically on our staff that's been ill? We've had a lot of staff that have been ill with this, and how that's going to affect their ability to work, doing this very difficult work, like what Cynthia does. That's really, really challenging work and amazing. But I think that is something we really need to think about, particularly the mental health aspects of this upon our workforce, and how we're going to support that and sustain that. It's very heartening to see that there's federal initiatives to try and work on those issues. But I think it's more important that there's value placed on that for our workforce at all levels of healthcare and all different types of providers, including our, as mentioned, the environmental services people. We can't forget them and all that. But I know for our EMTs and paramedics out in the field and our dispatchers, our 911 telecommunicators, that it's been a huge impact on them, both episodically as they're dealing with the instances out there that are very tragic and very different from how we traditionally have handled emergency situations, like a resuscitation, for example, and having to deal with family and not transporting patients, and what kind of the community our community here is accustomed to. And then also, how they're dealing with the chronic stress of the whole situation, and what that's doing to people, and how do we better support that and put a value on it, including frankly, it's a workforce. What's the monetary value on that society is willing to support, so that people can we can attract good people to do this very challenging work.
Thank you, Ben. And that's a good lead into the other conversation I wanted to have. And Molly, I'm going to single you out for this piece because having read your blog post, I think this really speaks to what you were writing about, and Ben started this conversation with talking about how do we address the mental health aspect of this pandemic. We think about the term moral injury, which has come into our vernacular, in the last couple of years, really out of the military, where this was a term first used back in after the Vietnam War to kind of address how soldiers were impacted for some of the atrocities they had to see or participate in. And we use this term now in our healthcare setting for some of the trauma that we're also exposed to. And I kind of wanted to get your insight, Molly, into kind of what you saw in New York, and how you felt what I think you expressed as moral injury when you were caring for patients in the heart of the pandemic at the time, and what were some of the factors that you had to deal with emotionally, and what resources did you have to manage those? And then I'll open that up to the rest of the group here as well.
Yeah, thanks, Steve. So I actually first, backing up, when I was in New York, a lot of us felt like really angry with what we were seeing and how unjust it was, just the care that people were getting in some hospitals compared to others that were like 2 miles away. And we felt like no one was talking about it yet. But EMS in general is a system where you are at the intersection of a lot of other failed systems, and you see people at their worst, and sometimes you feel like you're perpetuating these failed systems. You feel like you're not helping people the way that you want to be helping them. And I felt that way personally, like a lot of the time, just in my regular day-to-day job in EMS. But that was just like multiplied so much in New York, where I felt like I was just complicit in this system that wasn't serving the people who really needed help the most. And so I was there for 2 weeks, and then we got swapped out by coworkers at Pro who came down, and the truck stayed and we went back. And the paramedic who was replacing me, she's been in EMS for like a decade, and I love her. I have so much respect for her. But I was kind of explaining some of the challenges of the first, those 2 weeks, and she said, well, Molly, like, you probably haven't seen a lot of death before. And I was like, well, this isn't not having seen death. Like, I have seen death. This is seeing like structural failures that are causing like Black people, people like immigrants to die at just higher rates than white people, for example. And, but there's this culture in EMS where like burnout is normal. And I felt almost ashamed to be feeling this burnout, and I felt like I was weak and there was something wrong with me, like I wasn't tough enough to just like suck it up what I was seeing. And so this is sort of embarrassing, but I first started reading about moral injury in the context of COVID on Twitter, because I follow like a lot of doctors on Twitter, and I started seeing people describing their experience in that framework, and it was really cathartic for me to be like, okay, I'm not weak, there's not something wrong with me, I'm not cut out for this. I'm actually just feeling like I'm failing my own morals. I'm failing the people that I'm supposed to be helping. So that was really helpful for me to start like framing my experience that way.
Yeah, and that culture, unfortunately, is evasive across medicine. EMS certainly, but the ER, the ICUs, oncology, and it's something that certainly I have started to see some evidence that we're reversing that. And I think Twitter has been and I'm not getting paid by Twitter yet. Maybe I will after this. But no, Twitter has been a wonderful place for people to either anonymously or sometimes, identifying themselves to really discuss those emotions and to discuss how difficult this has been, and to find a support group, not just locally, but internationally, because we're going through this as not just a local, state, federal, this is a worldwide event. And it's been, I'm glad you mentioned that, because it's been a great resource, I think, for many of us, but it needs to be expanded upon at every level. Did anyone else want to comment on that?
I can surely add
Cynthia.
to this point about moral injury. That was a term I was first exposed to in a psychology class in nursing school, but it was like conceptually framed around childhood trauma and their experiences and how moral injury can result as a result of trauma. But within, healthcare, we have moral injury, but we also have moral distress that has emerged, particularly actually from the nursing literature. That has particularly increased during the time of the pandemic. And for me, injury and distress on a moral scale came from taking care of someone one day and then coming back and, hoping they're going to get better, but they decompensated or even passed away. That's happened to me at least 2 times that I can count on my hand. Letting families know over the phone that they can't visit their loved ones, even like ones that were dying or really decompensating, because we had to reduce the spread, especially in the beginning when we didn't really understand how severe COVID was. Again, like Molly mentioned, feeling I'm not doing enough for my patients. I feel like overwork and burnout is almost sensationalized in nursing, so, and across medicine, of course, but within nursing in particular, we never feel like we've done enough. Like but we have to be aware, and what I had to teach myself is that the effects of the virus are far more than what I can do on a personal scale, and I'm just here to help heal and mitigate damage as best as I can. And then watching my friends and colleagues contract the virus, even after we've all done everything that the CDC, our institutions had said to protect ourselves, that was particularly frustrating for me, because it was like, okay, then what can we do? If we're wearing the mask, we're wearing the N95, we're practicing putting our PPE for hours in a day before we get our first patient, what else can we do? And it really all manifested in the form of guilt and fear and anger and sadness, and then eventually just emptiness, because I had to relearn to desensitize myself because taking care of my first COVID patient instilled like a similar shock as getting my first patient as a nurse. And like when I first entered healthcare as a co-op student, like having that shock of, oh my God, I'm in the hospital, like I'm actually expected to provide care. You know, and much in children, that more injury among health professionals in the midst of such a traumatic time in our careers can really impact our growth and our coping and our ability to be fully present for those we care for.
Thank you. I think you phrased that wonderfully, and I appreciate that valuable insight. And that kind of leads me to another conversation I want to have, and I think I'm going to reach out to Dr. Oshri to discuss this, which is, you mentioned, you know, the absence of family presence, which I think has actually been incredibly distressing to healthcare providers across the spectrum. And I know that in oncology especially, that patient, you know, doctor-patient provider relationship is incredibly important. Those patients spend a lot of time in healthcare settings, and their family presence is incredibly important. And Dr. Oshri, I wanted to see if you could comment on, you know, what do you feel were the shortcomings of the approach to not just your, you know, maybe your institutions, but across the board when it came to, you know, kind of family presence and patient interaction?
Yes, thank you for that. I think that often patients would come to visits where they were going to hear the initial diagnosis and sort of the treatment plan with family members, with support. And I think everybody's familiar with the fact that, you know, when you hear bad news, everything that comes after it is pretty much a blur. And often having other people, you know, present, you know, during that visit is incredibly helpful. So, you know, we were not able to allow, you know, family members to come for outpatient visits, and inpatients also, you know, were not allowed visitors, not specifically COVID patients, but anybody in the hospital. So, you know, I think that there was a lot of isolation and, you know, just sort of like a lack of family support on account of that. You know, I think for me, there was also the issue of not being able to even have patients come in and having like televisits with them. And, you know, a lot of my patients actually did not have access to the electronic medical record. So they weren't able to do video visits when that, you know, sort of came to popularity. It was a lot of phone work, and sometimes we didn't even have good, you know, contacts, so had trouble setting up those phone visits. And, you know, I had recognized that most of my patients didn't have access to the electronic medical record, which really did facilitate care, you know, being able to send messages back and forth, being able to remind patients of their appointments, being able to check on them after chemotherapy treatments. And, you know, I realized that a lot of my patients just either didn't have the technological savviness. Some of them didn't have computers or even cell phones. There were like language barriers, and it really was something that hadn't been well addressed, you know, by my institution. I did actually, just before this conference began, receive an email with a working group that's looking at this. So, you know, I think that that's, to me, a sign of maybe some hopefulness, and maybe, I don't actually want to call it a silver lining, but, you know, something that will come from this that may turn out to be for the betterment, is that, you know, these shortcomings, this lack of ability to communicate, lack of access, language barriers, you know, things like that will be addressed in a more comprehensive way, and, you know, just for the better care of patients moving forward.
No, I agree, and I think that identifies just another inequity, which is access to technology. And some of our most vulnerable patients are the ones who don't have that technology. And, you know, our older, you know, patients who aren't comfortable using an iPhone or Zoom, or those who just don't have the funds to, you know, have an iPhone or to have a PC, to have a laptop, to be able to do those things. It just, again, shows that we have these inequities built into our system that failed us during these most important times. Any other comments? So the next, I think that again, the moral injury discussion will build on this next question to all of you, which is, what has been put in place to help address this in your institution? Have your institutions or institutions you're aware of developed any wellness programs or ways to address just the trauma, the moral distress, or even at the highest level, the burnout that some providers are facing? Ben.
Excellent point. Yeah, Steve, I would say that's, the $1 million question. Right? What are we going to do about that? Because there's been a lot of talk about it, and it's really heartening to see the current administration and Congress seems to be wanting to advance initiatives in that realm. But back at home, at whatever institution or organization we're working at, what are we doing? And is it sustainable? The biggest thing for me in EMS, and I would defer to my colleagues in the other areas, but I think I heard it what Dr. Oshry was saying and what Cynthia was saying and what Molly was saying, was that, it's great to have things that work every day, or things that work that we jury rig because people are excellent and they're going to rise to the occasion. But rising to the occasion for an incident like a spike incident, like what we had with the marathon tragedy, is one thing. Rising to the occasion and sustaining it on a very high plateau for a year is a whole different thing. So when we're dealing with these kind of issues, we need to have solutions that are sustainable, and that means real commitment, both in spirit but in funding, because the forgetfulness of these types of incidents is fascinating. Even in the past year, last summer, who noticed that as things got a little easier and our slope came down last summer, I'm sure my ICU friends and Doctor and Molly, you would remember that people got kind of loosey-goosey again, and we started to see people acting, and including management acting like, well, we can kind of go back to not treating the population, but treating individuals just like we did before. And we need to have a more sustainable response to these things, that we're ready for them, and we can also help our staff with mental health or whatever they need, including physical health, over a longer period of time. And there's funding for that. It's not magic. It can't be one-off stuff. 20 years ago, we funded billions of dollars in the United States post 9/11 for all sorts of preparedness for smallpox, anthrax, chemical weapons, washing people down in mass decon units, and all of that stuff rotted on the vine as our collective memory faded. So hopefully now we'll have a reinvigoration of that has to be sustainably funded at Congress, and then cascading down, and not just for emergency people like AMEs do, but for what Dr. Oshry was talking about, for the real majority work of healthcare, taking care of cancer patients. How many cancer patients in the last year died or got much, much worse because they weren't able to get access to their care that they normally would have? So those are my thoughts on that. The mental health part really needs to be addressed for our workforce and not in a one-time way. It has to be something that we look at long-term.
I'm sure the rest of you have something to add to that as well. Cynthia?
Yes, of course. I want to echo Ben's point about, aid to prepare for these situations. Obviously, a few people thought that COVID was going to devastate the world as it has, but unlike collectivistic societies and comparable healthcare systems, the U.S. isn't great at preventative care or primary prevention strategies. I'm from Nigeria, and I was born here, but my father was originally born there, and they don't go to the hospital unless they've broken a bone. They're very apt to take care of themselves and, naturally and holistically ensure that their health is at an optimal standard. And when it is not, or there are things that are past their own, like power to heal or fix on their own, then they go to the hospital. But they have a lot of things in place to prepare for, illness or shortcomings that we experience in this healthcare system that we are just simply not prepared for, no matter how much money we dump into it. And healthcare, and in particular nursing care, is becoming increasingly complex. And we need to recognize that for the sake of our patients, but also for the sake of our healthcare professionals, our nurses in general. We are advocates, we're educators, we're innovators, researchers and scientists, but we're also support staff and unit coordinators and whatever the situation calls for that day. And when we step up in the job done, we need to be recognized and supported and compensated accordingly. And as I stress in my written perspective, holding those government bodies and organizational administrators accountable for ensuring that we're valued and supported to the fullest capacity is also very important. And some of the legislative policies that I had mentioned was, one in particular was House Resolution 86 that will acknowledge the transcendent work of healthcare professionals during the pandemic. And address the issues of unfair treatment within patient care, but then also within the workforce. So I want to see nurses in particular become more empowered to advocate for policy change, at a state level, but then at a federal level as well. And then a change specifically that I'd like to see occur at a national level would be leveraging community liaisons in order to bring care to the forefront of marginalized communities, but also to reduce the care burden on healthcare professionals. Like community health workers, for example, they understand the social context of people's lives, and they're uniquely positioned to help vulnerable populations, which can be vital in the care of long COVID. And I'm currently working on a model of community health worker integration that I truly believe will help with care coordination and ensure proper utilization of health services. So I'm passionately in favor of that clinical community connections to significantly mitigate those long-term effects of the virus on our patients, but then also to support our clinical professionals who are not just burnt out and saying, hey, that's nursing, or hey, that's, being a EMT. That's just what healthcare is. Like, we won't normalize that anymore. We'll have partners who can help our marginalized people who are in the community and may not be taking that med that they prescribed as regularly as they should be. And we'll have partners that will help us do that.
Oh, thank you. Thank you. I want to build on that, and I want to ask, and I'm going to give everyone an opportunity to answer this question. Because as many negative things that have come out of COVID, I've seen there have been some real positives as well. I transitioned from the emergency department to the ICU during COVID in June because our needs there were high, and I found a new home in the intensive care unit. It's been a life changer for me because, in the emergency department, you see patients for a short period of time. In the ICU, the longitudinal care helps you develop some significant relationships with patients. I think my second day in the ICU, I'm like, what is that person still doing here? Because in the ER, we just move people through. But the ICU is longitudinal. And you get to form real relationships with patients and their families. And one of the things I've seen has been really that I think, our team has really developed just this tight-knit mentality where we care a lot for each other. Not that that didn't exist, but I think it's really helped tighten those bonds. And I also think that it's opened an opportunity for us to be a little bit more emotional about our bonds with patients and their families, where before we couldn't do that as much. It's a little bit more open that we can cry when one of our patients that's been in the ICU for a month dies. We can write or talk to that family on the phone days or even weeks after that experience, and I think that's been a positive. And so I want to give you each an opportunity to kind of talk about what areas both promise or hope that you think have come out of this, pandemic, and that you feel has helped to kind of strengthen the community of healthcare providers? And I'll start with Molly.
So this question is really hard because a lot of days I feel pretty down about where we're at and the ways that we've sort of moved backwards over the past year instead of forward, even apart from COVID. But I thought a lot about this, and I think a couple of things. What Cynthia mentioned earlier, the way that we've amplified other healthcare workers that aren't physicians, I think only helps everyone and only helps patients, and especially the way that nursing, I think, has been amplified over the past year brings me a lot of hope. And I think people have a great understanding of what nurses do every day, what healthcare workers do every day, which again, I think only will help patients and only help our profession. Another thing is we're talking about racism as a social determinant of health more than we ever have before, which I think is amazing. I got a master's in public health 4 years ago, and I don't think we talked about racism as a determinant. We talked about race. So just the fact that that's a national conversation, granted, I'm in an echo chamber, I know that this conversation isn't happening everywhere, but it's definitely a start. And that brings me a lot of hope. And just the fact that equity has become a buzzword, it can be a little bit, that it's a buzzword now, but at the same time, people are talking about it and it's really, really important. So those things bring me hope and make me excited.
Well, that's good. That's good to hear. And Dr. Oshry, how would you like to respond to that?
I would like to say that Molly brings me hope, because to hear what she went through, and Cynthia and Ben too. I mean, it's really, I think, incredibly inspiring that, we've been kind of beaten down, but it hasn't defeated us. And, to hear Molly go through her experiences and yet still, be enthusiastic about, relatively enthusiastic about her nursing studies, and I think poised to change things is really a tremendous upside of this. I think when I graduated from medical school, I really knew that I wanted to, I didn't realize that it was address disparities at the time, but I knew I wanted to work in a, safety net hospital. I knew I wanted to work with vulnerable patients. I really don't think I recognized it. I really recognized structural racism. I think a lot of things we accepted then that we don't accept now. And I think to the extent that the pandemic has focused a light on that, and brought attention to it, and that may bring change, that people like Molly, and Cynthia and Ben are sort of coming up in this period, ready to continue to speak about this and change it. It is a wonderful thing.
Ben, I'm going to shoot it over to you.
Thank you. I would definitely echo that. Those really nice remarks. Yeah, I would say that, it's on the positive side is just this, right? Is that we're talking about these issues and they bring them to the forefront. It certainly hasn't been a positive year. We've lost, hundreds of thousands of people, and other people have been sickened here in the US and around the world. So, but as far as what's happened, it's certainly demonstrated the resilience and the motivation and care of the workforce, and that's very heartening to see, and it's inspiring. I think very inspiring. But I think aside from that is that moving forward for what I do, emergency medical services, is the opportunity for EMS is to make sure that we advocate for it, because it is the hidden emergency service. It's not, and it lives in kind of a funny intersection between healthcare and public safety. And it's time for it to be recognized for what it did during the pandemic. It has always done, but it's kind of been marginalized over the several decades since it was funded. Its funding was lost in the 1980s from the federal government, so, or it largely was. So it's time for that to come back. It's time for a more enhanced look at how we can be ready for disasters, but also how we can be ready every day. That's not just based on whether a community is wealthy or whether it's not. It should be, to some of Cynthia's excellent points, it should be equitable across the board. Everyone should have access to high quality acute and primary and specialty care. And that should be an equitable thing that we sustain, not just for disasters and pandemics and catastrophes, but for every day. And we need to advance that. I know EMS does. So EMS needs to step into the forefront as far as being a focus for a post-pandemic improved emergency response system.
Thank you. Cynthia.
I'll be brief because I know we have such limited time here, but to kind of jump off of Molly's point of equity being a buzzword, which the reality is that it is. The science community just started speaking about it more heavily with, the recent protests and recognizing COVID as not the great equalizer that we thought it was, but Black and brown people have been experiencing it their entire lives. Like my father immigrating here from Nigeria in the 80s has experienced it from that point he came to the US to now. I've experienced that as a healthcare professional, as a student nurse. There are people who have limited English proficiency or experiencing it every day they step into an office. So ensuring that the research and the work that we do surrounding health equity is not just this savior complex. We're going to go, and save everybody who has ever experienced racism in healthcare, but to really understand through participatory research and design to ensure that our innovations and our research are really helping the folks that we're intending to help, rather than just getting a medal because we saw that Black people are more susceptible or Latinx people are more susceptible. And to touch on that too, we're going to stop using race as like a crude proxy to explain really complex structural inequities that are the true cause of increased susceptibility, increased mortality, increased morbidity. We'll stop eventually. I'm hoping soon, but that's what I envision for the future.
Well, great. And we are close to running out of time. So I'm going to borrow something from NPR and the show Wait, Wait, Don't Tell Me, which is kind of my favorite segment of the show, where Peter Siegel asks his panel and panelists to give us the headline, next year's headline for COVID-19 in the healthcare workforce. So if you were to give the Boston Globe or other papers headline for COVID-19 and the healthcare workforce, Ben, what would that be?
I think my repeated mantra today has been sustainability for the healthcare workforce, whether it's EMS, nursing, physician care, that it needs to be sustainable, that our preparedness for major events needs to be something that isn't just a problem once it's happened, that it's something that we're ready for moving forward, and on all fronts, not just having equipment. And that's certainly been a huge problem with the degradation of the historic funding for that. But particularly, that we're attracting great people like we have on this panel to the workforce. We're able to sustain and keeping them, and doing that by taking good care of them in environments that are supportive in all the kind of ways they need to be, whether it's mental health, pay and benefits, and also time off. And that's something that society, if they don't care about it, that's a problem, because these are the people that have been saving, and these people on the panel here, including yourself, are the people who have been saving lives during this pandemic.
Great. All right, quick lightning round one-liners. Molly, what would your headline be?
Okay, so I'm going to end with some humor. A year from now, maybe we'll see that telemedicine has gone so far that young people get all of their medical advice from TikTok. So,
I love it. Cynthia.
This is something I feel on very many levels of my identity, but just because we carry it well doesn't mean it isn't heavy.
Love that. Dr. Oshry.
Wait, Steve, I think you and I might be the only people that actually listen to Wait, Wait, Don't Tell Me. Because
we might be, yeah.
It's supposed to be funny, right? Okay, so
yes, yes.
Jeff Bezos donates the $24 billion he made during the pandemic directly to safety net hospitals to improve resources. And only healthcare providers, not the administrators, can access the funds, but everything has to be purchased on Amazon Prime.
And everything I have purchased lately has been on Amazon Prime. So perfect finish to that. Thank you to our panelists. Thank you for everyone who participated today. A special thanks to Petrie-Flom, Chloe, Laura, Carmel, et al. It's been a wonderful event, and I thank you for everyone's insight. Please make sure to visit the Petrie-Flom website for other events coming up, and especially the Bill of Health blog to visit our digital symposium. Thank you, everyone.